So you developed this unified protocol which is designed to sort of focus on manifestations of this underlying neuroticism. Question that I had is, you have these different modules and the idea that every patient goes through all of these different modules. How do you think that the clinician working with the patient should sort of go through them uniformly, or do you think that they should be somewhat adapting them for personalizing them? And if so, how to go about doing that?
Yeah, well, that's an excellent question. Right on the cutting edge of research. And although I'm not actively involved in grants and research anymore, many of my former proteges, former postdocs and students are. And that's exactly what they're working on. These protocols are and ours is a protocol, even though it's transdiagnostic and coherent. It's still a protocol, and it's never meant to be applied rigidly. I mean, that's why we all get clinically trained. If it's meant to be applied rigidly, you wouldn't need clinicians. You could just have an AI agent do it or something. To back up a bit, for example, to support that, one of the problems we would have in our clinical trials was we'd be required to, very wisely, when we're doing clinical trials, make sure we had an independent variable, which would be the treatment procedure. Well, to do that, we'd have to develop these adherence and competence scales that would be applied to every therapist, somebody who would be responsible for the adherence and competence ratings. They have to look at a sample of the videos of them delivering the treatment. Well, what we found early on was that we would occasionally, and there'd be, 20, 30 therapists involved in some of these large trials. What we discovered early on is that we would occasionally get these people who scored perfectly on adherence and flunked on competence. We say, and we would just see the numbers and see, what the hell's going on here? And we maybe bring the rater in and look at everything. And what would happen is that these people were just reading the manuals. They were just reading the manuals with almost no regard for, personalizing it, doing the art of the clinical work, and making sure that they understood it and applied to them, adjusting it to their context, their surroundings, their understandings, their idioms. The therapists were very incentivized to do this, some of them, because we're getting paid for it. And they wanted to keep being therapists. For some of them, that was, was a motivation. I mean, they were good people. They were trying hard, but these protocols were never meant to be, they're always meant to be personalized. Then it brings us to your question. But how should they be personalized? What are the guidelines here? You can't just go out like, the traditionalists did for all these years and say, go out and just form a good relationship. The best you can, get the patient to like you and all. And I said, what are the guideposts for making these clinical decisions? Do the patients necessarily need all 5 of our core modules in the unified protocol? Maybe they don't need the motivational portion. So we're now developing, and we have developed actually, we're in the process of developing some assessment procedures whereby we'll look at the various levels of skill. Marshall Linehan, the borderline DBT people, do this too. What are the skills, whether it be, the cognitive kind of skills, the cognitive understanding, et cetera, the exposure. What are the kind of skills that these people already have that maybe we don't need to really work with them much on that, but we need to focus on ones maybe they're particularly weak. So that's an area that's under heavy, the number of grants in that area now. So it needs to be personalized. Yeah.
Because that was exactly the motive, because you have a motivation module. And one of the things that I thought about is, sometimes you have a patient who comes in who's really motivated, right? And then it was like, so then how would you sort of make that determination? But it sounds like that work's going on.
Right. So, but in our lab already, clinically, people say, well, we just don't spend much time on that. Yep, this patient's good on that one. We'll move right on.
Right.
Right. So, we do have a range of sessions for each of the 5 core modules. And that's sort of meant to accommodate the individual adaptations by the clinician. But we're trying to come up with something maybe a little more systematic.